Meningitis is inflammation of the protective membranes covering the brain and spinal cord, collectively known as the meninges. The inflammation is caused by infections with bacteria, viruses, or other microorganisms, less commonly by certain drugs. Meningitis is a life-threatening condition because of the inflammation being near the brain and spinal cord, classifying it as a medical emergency. The most common symptoms of meningitis are headache and neck stiffness associated with fever, confusion, or altered consciousness, vomiting, and inability to tolerate light or loud noises. Children often exhibit only nonspecific symptoms such as irritability and drowsiness. If a rash is present, it may indicate a particular cause of meningitis. For instance, meningitis caused by meningococcal bacteria may be accompanied by a characteristic rash. Meningococcal disease occurs in epidemics, usually in areas where many people live together for the first time, such as army barracks, college campuses, and the Hajj pilgrimage. Some suggest that Hippocrates may have realized the existence of meningitis, and it seems that meningism was known to pre-Renaissance physicians such as Avicenna. It appears that the epidemic meningitis is a relatively recent phenomenon. The first report of bacterial infection underlying meningitis was by the Austrian bacteriologist Anton Fischelbaum, who in 1887 described the meningococcus. The death rate from meningitis was very high, over 90%, in early reports. In 1906, antiserum was produced in horses. This was developed further by the American scientist Simon Flexner and markedly decreased the death rate from meningococcal disease. In 1944, penicillin was first reported to be effective in meningitis. The introduction in the late 20th century of Haemophilus vaccines led to the marked fall in cases of meningitis associated with this pathogen. And in 2002, the evidence emerged that treatment with steroids could improve the prognosis of bacterial meningitis. In adults, the most common symptoms of meningitis is severe headache occurring in almost 90% of cases of bacterial meningitis, followed by neck stiffness of the nape area of the neck. The classic triad diagnostic signs consists of neck stiffness, sudden high fever, and altered mental status. However, all three features are present in only 44 to 46% of bacterial meningitis. If none of the three signs is present, meningitis is extremely unlikely. Other signs commonly associated with meningitis include intolerance of bright light or loud noises. Small children often do not exhibit the aforementioned symptoms and only may be irritable and look unwell. The fontanelle can be bulged in infants up to 6 months. Other features that distinguish meningitis from less severe illnesses in young children are leg pain, cold extremities, and abnormal skin color. Meningitis is typically caused by an infection with microorganisms. Most infections are due to viruses, with bacterial, fungi, and protozoa being the next most common causes. It may also result from various non-infectious causes. The term aseptic meningitis refers to cases for meningitis in which no bacterial infection can be demonstrated. This type of meningitis is usually caused by viruses, but it may be due to a bacterial infection that has already been partially treated. When bacteria disappears from the meninges, or pathogens infect a space adjacent to the meninges. Meningitis may be encountered in cerebral malaria or amoebic meningitis due to infection contracted from fresh water sources. Recurrent bacterial meningitis may be caused by persistent anatomical defects, either congenital or acquired by disorders of the immune system. Anatomical defects allow continuity between the external environment and nervous system. The most common cause of recurrent meningitis is a skull fracture, particularly fractures that affect the base of the skull or extend towards the sinuses. Approximately 59% of recurrent meningitis cases are due to such anatomical abnormalities. 36% are due to immune deficiencies, and 5% are due to ongoing infections in areas adjacent to the meninges.
The brain tissue may swell, pressure inside the skull may increase, and the swollen brain may herniate through the skull base. This may be noticed by a decreasing level of consciousness, loss of pupillary light reflex, and abnormal posturing. The inflammation of the brain tissue may also obstruct the normal flow of CSF around the brain. Seizures may occur for various reasons in children. Seizures are common in early stages of meningitis and do not necessarily indicate an underlying cause. Seizures may result from an increased pressure from areas of inflammation in the brain tissue. Focal seizures, persistent seizures, late onset seizures, and those that are difficult to control with medication indicate a poorer long-term outcome.
Inflammation of the meninges may lead to abnormalities of the cranial nerves, which control, among other functions, eye movement, facial muscles, and hearing. Visual symptoms and hearing loss may persist after an episode of meningitis. Inflammation of the brain or its blood vessels, as well as the formation of blood clots in the veins, may all lead to weakness, loss of sensation, or abnormal movement or function of the part of the body supplied by the affected area of the brain. Mechanism. The meninges comprise three membranes that, together with the cerebral spinal fluid, enclose and protect the brain and spinal cord. The pia mater is a very delicate and permeable membrane that firmly adheres to the surface of the brain, following all the minor contours. The arachnoid matter is a loosely fitting sac on top of the pia mater. The subarachnoid space separates the arachnoid and pia mater membrane and is filled with cerebral spinal fluid. The outermost membrane, the dura mater, is a thick, durable membrane which is attached to both the arachnoid membrane and the skull. The large-scale inflammation that occurs in the subarachnoid space during meningitis is not a direct result of bacterial infection, but can rather largely be attributed to the response of the immune system to the entry of the bacteria into the central nervous system. When components of the bacterial cell membrane are identified by the immune cells of the brain, they respond by releasing large amounts of hormone-like mediators that recruit other immune cells and stimulate other tissues to participate in an immune response. The blood-brain barrier becomes more permeable, leading to swelling of the brain due to fluid leakage from blood vessels. Large number of white blood cells enter the CSF, causing inflammation of the meninges and leading to swelling due to fluid between the cells. In addition, the walls of the blood vessels themselves become inflamed, which lead to decreased blood flow and cytotoxic edema. The three forms of cerebral edema all lead to increased intracranial pressure. Together with the lowered blood pressure often encountered in an acute infection, this means that it's harder for the blood to enter the brain. Consequently, blood cells are deprived of oxygen and undergo automated cell death. Untreated bacterial meningitis is almost always fatal. Viral meningitis, in contrast, tends to resolve spontaneously and is rarely fatal. With treatment, mortality from bacterial meningitis depends on the age of the person and the underlying causes. Of newborns, 20 to 30% may die from an episode of bacterial meningitis. This risk is much lower in older children, whose mortality is about 2%, but rises again at about 19 to 37% in adults. Risk of death is predicted by various factors apart from the age, such as the pathogen and the time it takes for all the pathogen to be cleared from the cerebral spinal fluid. The severity of the generalized illness is a decreased level of consciousness or an abnormally low count of white blood cells in the CSF. Meningitis caused by influenza and meningococcus has a better prognosis than cases caused by group B streptococcus, chloroforms, and S. pneumonia. In adults too, meningococcal meningitis has a lower mortality, 3 to 7%, and pneumococcal disease. In children, there are several potential disabilities which may result from the damage to the nervous system, including hearing loss, epilepsy, learning and behavioral difficulties, as well as decreased intelligence. These occur in about 15% of survivors. Some of the hearing loss may be reversible. In adults, 66% of all cases emerge without disability. The main problems are possible deafness and cognitive impairment. For EEG text is that meningitis can appear as focal slowing, status epilepticus, and everything in between. We hope you enjoy the presentation and learned something about meningitis.